Perfect. Well, welcome everybody. Thank you for joining us for one of the Education Committee's NKC Professional Development Series talks. We are very excited to have Dr. House with us today. Dr. House is an assistant professor in the Division of Pediatric Nephrology at the University of Wisconsin-Madison and a palliative care researcher who leads the Thrive Kids Research Group, the first group of its kind devoted to palliative care in pediatric nephrology. She's passionate about increasing palliative care delivery for children with serious illness, and particularly those with kidney disease, to help them live as well as possible given the constraints on their illnesses. Her research focuses on developing person-centered holistic interventions to activate children with kidney disease and their families in their care to bring about improved health outcomes. Thank you for joining us, Dr. Taylor. We're really excited to have you, and I will let you begin. For those who are joining us, we will plan to do a Q&A at the end. Dr. House has been kind enough to leave a few minutes of time for discussion at the end of the hour. So if you could put your questions in the chat or save them until the question and answer session, we'll do that at the very end, and we'll post a survey for you all at that point too. So Dr. House, I think we're ready. Thank you for being here.
Yeah, thank you. Thank you so much to the coordinators for inviting me to. I really appreciate the opportunity. As Heidi said, my name's Taylor House. I'm a pediatric nephrologist and palliative care researcher at the University of Wisconsin-Madison, and I lead the Thrive Kids Research Group. So that just stands for Total Health Research, Investigating Values and Empowerment in Kidney Disease. And we really focus on ways to incorporate principles of palliative care in the care for children with kidney disease. And as a pediatric nephrologist who also has some additional palliative care training, I lead a clinical program here in which I provide palliative care for the children who are in our local kidney program. Today, I'm going to be talking about supporting parents of children in the NICU to help them to move from crisis to connection and ultimately flourishing through the integration of palliative care. I think we can all agree it's distressing to have a child in the NICU, particularly one who has kidney disease. And palliative care offers a way to address that distress and potential suffering and to improve family experiences. So today we'll describe those potentially distressing parental experiences in caring for their child who has neonatal kidney disease. I'll outline some palliative care approaches that we can use to minimize distress among these parents. And then I'll wrap up today by discussing some opportunities for post-traumatic growth and for flourishing among these parents, a state in which all aspects of their life are good. I'd like to start with a case that's just kind of an amalgamation of children that I've served and that you've probably also encountered. I'd ask that you imagine that you're caring for a now 2-day-old who was born at 31 weeks gestation. He had a prenatal diagnosis of a suspected solitary kidney, but after delivery, it was actually discovered that the single kidney that he does have has some cystic dysplasia. His creatinine was 1.2 when he was admitted to the NICU, and it's currently 1.6. And over the last several hours, he's had some temperature instability. So he's undergoing a rule out and necessarily is needing to receive ampicillin and gentamicin and acyclovir. The team has also determined that he has a pretty big PDA, and he also was found to have choanal atresia. So right now he's intubated. The parents of this baby did not expect the degree of congenital anomalies that their child has or the level of care that he needs to receive. They're also really being inundated with medical information. They have a 3-year-old at home who isn't able to visit the NICU, and they're struggling to determine their role as parents in this bustling machine of the NICU. They are encountering grief. They're mourning the delivery and the postpartum course that they had hoped and that they had planned for. And they're also potentially encountering trauma that's associated with their baby's health demands. They and their family are at high risk of failing to flourish. I'd like to suggest to you that this family is a candidate for specialty palliative care, and there are palliative care principles and tools that we can implement as nephrologists and neonatologists to best serve this family as well. So keeping that case in mind, I'd like to define a couple of terms that might be used to describe somebody's experience that you'll hear me use throughout the talk so that we can have some shared vocabulary around this discussion. Of these, the least specific, most generic is distress, which you can just think of as an unpleasant emotional experience that is psychological, social, or spiritual in nature. Grief is a particular type of distress that's associated with loss. And I suspect that most, if not all, parents of infants in the NICU encounter some amount of grief, of pain, or other emotions that come along with loss. One of the most illustrative examples of grief that I've run across in my work is this poem called Welcome to Holland, but written by Emily Pearl Kingsley. And in it, she describes her personal experience of raising a child with a disability. But I suspect there is a lot of overlap with the grief associated with having a child in the NICU, too. And in it, she writes, when you're going to have a baby, it's like planning a fabulous vacation trip to Italy. You buy a bunch of guidebooks and you make your wonderful plans. The Colosseum, the Michelangelo David, the gondolas in Venice. You might learn some handy phrases in Italian. It's all very exciting. After months of eager anticipation, the day finally arrives. You pack your bags and off you go. And several hours later, the plane lands. The flight attendant comes in and says, "Welcome to Holland." Holland, you say? What do you mean Holland? I signed up for Italy. I'm supposed to be in Italy. All my life, I've dreamed of going to Italy. But there's been a change in the flight plan. They've landed in Holland, and there you must stay. The important thing is that they haven't taken you to a horrible, disgusting, filthy place full of pestilence, famine, and disease. It's just a different place. So you must go out and buy new guidebooks, and you must learn a whole new language, and you'll meet a whole new group of people you would never have met. It's just a different place. It's slower paced than Italy, less flashy than Italy. But after you've been there for a while and you catch your breath, you look around and you begin to notice that Holland has windmills and Holland has tulips. Holland even has Rembrandts. But everyone you know is busy coming and going from Italy, and they're all bragging about what a wonderful time they had there. And for the rest of their life, you will say, yes, that's where I was supposed to go. That's what I had planned. And the pain of that will never, ever, ever go away because the loss of that dream is a very, very significant loss. But if you spend your life mourning the fact that you didn't get to Italy, you may never be free to enjoy the very special, the very lovely things about Holland. I think she really beautifully describes that experience of grief, the loss of the parenting experience that she had expected. And grief can be a potentially traumatic experience. So when I talk about trauma, trauma is a disturbing experience that causes feelings of fear, helplessness, or just generally disruption that can have long-lasting effects. When someone has trauma, it means that the assumptions that they have held about the world, in our sample case, that this family would have a healthy term baby, are violated. Post-traumatic stress symptoms are things like intrusive thoughts or images, physiologic reactivity, avoidance, maybe feelings of numbness or detachment, or even dissociation, and that these symptoms have a negative impact on somebody's mood. When those post-traumatic stress symptoms persist for over a month, they then meet criteria for the diagnosis of post-traumatic stress disorder. Trauma-informed care is a related concept to these terms, and I'll get to that just a little bit later in the talk too. So when somebody lives through some type of intense distress, and in the NICU that might be grief, that is a potentially traumatic experience. And while most people won't go on to develop PTSD long term, there is a portion of people whose experience continues to cause them trauma symptoms and impairs their daily life consistent with PTSD. For a variety of reasons, some of which I mentioned with our case, parenting an infant with kidney disease can be traumatic. We don't have numbers specific to families experiencing neonatal kidney disease, but among families in the NICU, the prevalence of postpartum PTSD is much higher than that of all-comer birthing parents. In all birthing parents, PTSD prevalence is estimated to be about 2%, but as many as 1 in 3 parents have post-traumatic stress symptoms as far out as 18 to 24 months postpartum. And in one study, those symptoms actually persisted for up to 5 years out from their NICU experience. In another qualitative interview study among mothers of infants who required NICU care, over half of them experienced re-experiencing avoidance, heightened arousal, all post-traumatic stress symptoms. And while most of this data is among mothers, there's also concerning evidence that the non-birthing parents, and typically that's specific to the fathers, are at high risk of developing PTSD, and that the impacts on them may actually be underestimated. In one study, a third of fathers of NICU patients met criteria for PTSD at 4 months postpartum. And some researchers have hypothesized that fathers encounter unique factors that could lead to more distress and potential trauma, like being the first parent to see their child, to see them in the NICU in this stressful environment, the demand to be a partner more than a parent at times as they're supporting the birthing parent, and that they may just generally have less time away from work. Certainly, the prevalence of trauma among parents has implications for their own physical and mental health, but there are also direct impacts to that child. Maternal PTSD symptoms related to premature birth are associated with more controlling and less sensitive maternal behaviors. Mothers with preemies are at a higher risk of reporting sleeping, eating, and behavioral problems at 18 months in their children compared to mother term baby dyads. And generally, maternal distress can result in adverse caregiving, exacerbating some of the behavioral problems that among children who are born premature. That can also contribute to vulnerable child syndrome, which is this phenomenon in which parents perceive their child to be medically fragile, that could then lead to medical services being overused, unnecessary interventions, poor parent-child attachment, and then negative impacts on that child's development. And there really isn't data available to elucidate the impact on other family members, like siblings of the infant or grandparents, or even the family as a whole. But certainly the ripples of that NICU experience are expected to touch all of the family members. Now, changing populations just slightly, parenting a child with kidney disease, including neonatal kidney disease, can similarly be trauma-provoking. In focus group studies of caregivers of children on dialysis, many of them described feeling like they needed to surrender parenting once they learned that their child had advanced kidney disease. In a survey study of caregivers of children on dialysis, over 2/3 indicated that dialysis initiation was traumatic for them. And from the NICU literature, parents describe that machines like ventilators can be both physical and metaphorical barriers between them and their children. And I would expect that parents would similarly describe kidney replacement therapy machines like Aquadex, Carpe Diem, Prismax. This is a thematic schema from my own group's research describing the traumatic experience of dialysis initiation for parents of children on dialysis, including those who did initiate some kind of dialysis in the NICU. When we interviewed these parents, when you start in the bottom left corner triangle, they described that when their child started dialysis, they experienced this acute disruption in their ability to fulfill their parenting role. Mostly this was because of the abrupt emergent circumstances that their child's care required and the lack of medical knowledge that they had, and then this demand, this need to rapidly acquire more. As their child's care progressed, moving to the top triangle there, they felt tasked with now needing to redefine their parental role. They realized that they needed to now develop this second identity as a medical provider. And that additional second identity was fostered through the understanding that their child was likely to survive dialysis initiation, granting them permission to hope through the communications that they had with the medical team, and then by engaging in care plan development, even when the choices were functionally limited. And then finally, in that bottom right triangle, caregivers worked to leverage their established role of caregiver and now this newly realized role of medical provider to positively impact their child's experience through empowerment, through being vigilant in their child's care, and developing an ability to adapt to abrupt and unexpected changes in their child's care journey. If that evolution wasn't nurtured, then when they encountered future acute fluctuations and potentially traumatic experiences in their child's care, it could contribute to future disruption of their parental role, moving back to that bottom left triangle, or the need to redefine their roles again, represented by that top triangle. And as children with kidney disease age, studies among them similarly show that it can be fraught with traumatic experiences. In a study of pediatric heart, liver, and kidney transplant recipients, and I just want to emphasize that these kidney transplant recipients are living with the ideal treatment for kidney failure. The kidney transplant recipients had more significant trauma scores than their heart or liver transplant counterparts. Not surprisingly, PTSD is present in over 40% of kidney transplant recipients. And I mentioned that we don't have data on the potentially traumatic experience of siblings of infants in the NICU, but among siblings of children with kidney disease, the siblings themselves, experience emotional distress related to fear about acute changes in their siblings' health. They have less time with their parents, and they feel like limits are placed on their lives because of their siblings' kidney disease. So, being a parent or a family member to a child in the NICU or a child with advanced kidney disease, or just living as a young person with advanced kidney disease presents a high risk of experiencing trauma. The way that I would say that is that they are operating in a hostile environment. And it's important for us to understand and implement ways to make it a safer place for them. Another way to think about this is that collectively, these families and children are at a high risk of failing to flourish, of being unable to attain a state in which all aspects of life are good. At its very fundamental level, to palliate means to alleviate suffering. And through integrating palliative care in our routine NICU and nephrology care, it offers us a chance to lessen or mitigate this suffering. And subsequently, with alleviating that suffering, what I would suggest is that it offers us the opportunity to enable their flourishing. So, I'd like to talk a little more about how we can minimize suffering and ultimately promote flourishing through the incorporation of palliative care for cases just like that first one that I introduced. The Center to Advance Palliative Care defines it as specialized medical care for children living with a serious illness. Just to give a little more context, when they say serious illness, they're defining that as a life-limiting or a life-threatening illness, which I would suggest includes a significant portion of our collective patients, including that hypothetical first case. Palliative care focuses on providing children and their families with relief from the symptoms and stress of a serious illness, and the goal is to improve the quality of life for both that child and their family. And they go on to say that palliative care is based on the needs of that child, not on their prognosis. It's appropriate at any age and at any stage in a serious illness, and it can be provided alongside curative treatment. Providing palliative care is an understanding that the circumstances in which these kids with kidney disease and their families are growing and developing aren't ideal, but palliative care offers a way to move from suffering to enabling their flourishing. As another way to visualize this, I use this figure in my work to illustrate that concurrent nature of palliative care and pediatric nephrology care. Palliative care and disease-oriented care are complementary throughout someone's lifetime. And as that patient and their family move through their disease experience, their goals evolve, their kidney disease progresses, palliative care can take a larger role, represented by that purple diamond in the center, ultimately with a transition toward kidney transplant and survivorship, or hospice and bereavement. To realize that concurrent care delivery to enable their flourishing, it's also important that we understand the domains of the holistic care that are delivered through palliative care. So, what exactly does palliative care involve? It really focuses on 3 domains of care, and those include physical symptoms, so attending to things like pain, nausea, vomiting, itching, so on. Psychosocial distress, managing things like depressed mood, feelings of anxiety, or post-traumatic stress symptoms. And high quality communication, family-centered communication that focuses on eliciting and then incorporating what matters most to a child and their family. And attending to those three domains is layered in excellent coordination of interdisciplinary care across settings and across stages of illness. So, at times like when they transition out of the NICU to the general care floor, or from the hospital to the clinic, into the dialysis program, into the kidney transplant program, and so on. And in addition to these domains, palliative care can also be either primary or specialty, or secondary, is another way that you might hear that referred to. And I want to acknowledge that distinction in palliative care delivery, and that both primary and specialty palliative care, I think, have a role in caring for infants with kidney disease and their families. Primary palliative care is something that all of us interdisciplinary team members, clinicians, social workers, nurses, psychologists, all have a responsibility to work as a team to provide. So, thinking back to those three domains, when we provide primary palliative care, we're focusing on basic symptom management, diagnosis and treatment of depression and anxiety, and attending to psychosocial challenges, and delivery of high quality family centered communication. And then in some cases, the needs can become more significant, requiring that we include the specialty palliative care team. That might be cases in which a child is experiencing refractory symptoms or complex existential suffering, or maybe when communication needs are really pronounced, like when there's a disagreement between family members or even the family and the care team. For many of the infants and families that we serve, we have the privilege of developing a rapport and a relationship with them over months. And for those of us who are nephrologists, even over years, we really get to know them and their families very deeply. And that continuity and intimacy places us in a really unique position to be able to deliver primary palliative care and attend to those needs. I also want to highlight, though, that not all of the means to enable flourishing must or even really should be performed by a nephrologist or a neonatologist, but they should be taking place in our daily care, whether that's in the NICU, the general ward, or the nephrology clinic. And every child in the NICU, and certainly I think every child with kidney disease in the NICU, deserves palliative care, be that primary or specialty. We are well accustomed to drawing on the expertise of our teams and leveraging our available resources. And I think those same rules apply for palliative care delivery. Leveraging those resources that we have access to can be really pivotal in those first two domains, in attendance to symptom management and attendance to psychosocial challenges. But I think in that third domain, all of us individually every day are delivering family-centered communication. So I want to specifically highlight what primary palliative care could offer in cases like this, with a particular focus on that domain of serious illness, family-centered communication. And I think the easiest way to answer that first question is really to describe what high-quality, family-centered serious illness communication involves. And then I'll also offer some specific tools that you can apply now into your daily practice. The first palliative care rooted component of high quality communication is that it intentionally demonstrates empathy. And the specific skill that I want to offer is the use of something called nurse statements. Brene Brown is a research professor at the University of Houston in the School of Social Work. I'm sure many of you have read some of her work. She's really well known for her work that studies vulnerability and shame and worthiness. And I love the way she describes empathy as a way to be with people in their emotions. She says that it's what drives connection. And it requires four components. It requires that we try to take the perspective of others, that we stay out of judgment, that we recognize an emotion in somebody else, and then that we communicate that we have recognized that emotion. And she draws this distinction that empathy is different than trying to say something that makes a hard situation better. Sometimes empathy might look like saying something like, I don't even know what to say. I'm just really glad that you told me. Empathy is feeling with people and recognizing that a response can't make something better, but what makes something better is connection. There's inherent value in empathy in that it fosters that connection between us and families. There's also convincing evidence that empathy improves outcomes. First, empathy helps to create a healing environment. So when patients and families experience empathy, that in turn can increase trust and rapport, which then increases patient and family satisfaction and decreases things like anxiety. And in order to deliver medical care, there has to be this exchange of information for patients and families to make decisions about treatment options. So when we demonstrate empathy, we can increase information exchange and retention and then improve shared decision making, while also translating to improvements in things like self-efficacy, health behaviors, and ultimately outcomes. So how does empathy do all that? How does it improve decision making? We all make decisions with two important parts of our brain. We have that emotional, fast acting part of our brain, our fight or flight response, that we can think of as the fast loop. And that's really helpful when we need to make a quick decision because it typically uses our past experiences to inform rapid action. But when it comes to making medical decisions, generally people need more time and information to make the best decision that matches up with their values. So when we respond to emotions with empathy, that allows the cognitive part of our brains, that slow loop, to catch up and then work synergistically with the fast loop so that we can reason through different choices. Not only does empathy improve decision making, but it also takes a pretty small investment to make a big difference. In one study, just 40 seconds of empathy was shown to reduce patients' anxiety in a significant way. And in a study among primary care visits, when clinicians responded to emotion cues with empathy, on average, they saved 3 minutes per encounter. So if you saw 20 patients in a day, that could save you upwards of an hour. One of the founders of Vital Talk, which is a communication curriculum I'll talk about a little bit more briefly, describes it this way, saying that good communication takes time, bad communication takes more time. And I want to make the point too that a similar study hasn't been done in pediatrics. We don't actually know in pediatrics if it improves empathy or improves efficiency. But what I would offer to you is that even if it doesn't improve efficiency for us as pediatricians, that it's still worth doing. It still has inherent value because of those reasons that I've discussed. Okay, so I think we can agree it's important for our patients and for us. So how do we go about demonstrating empathy intentionally? The Nurse's Mnemonic is an evidence-based tool created by Vital Talk. So again, that is an evidence-based communication curriculum, and I'll show you some of their additional resources towards the end. And instead of trying to cover the emotion with a silver lining, nurse statements are a way that we can find connection and then walk with our patients and their families. And the mnemonic for nurses here stands for name, understand, respect, support, explore, and silence. So when we're faced with a statement of emotion, these offer some potential ways to communicate that we recognize that emotion. I'll talk through these and then we'll go over a couple of examples too. So a name nurse statement just acknowledges the emotion, calls it out and names it. When we do that, though, we want to be careful that we suggest how somebody feels. We don't want to necessarily tell them how they feel because they don't want to be told that, but they can appreciate the acknowledgement. So generally, when we use a name statement, we want to try to kind of turn down the intensity on an emotion. So instead of saying something like, you seem scared, maybe saying something like, you seem really concerned. An understand statement acknowledges or normalizes the situation. And we want to avoid suggesting that we actually understand their experience because oftentimes we can't. And if we do that by saying that we actually understand, then it can be really minimizing to somebody's experience. A respect statement is an expression of praise or gratitude about the things that that person is doing that you genuinely are in respect of. And that can be especially helpful whenever there is times of conflict. A support statement is an expression of what you can do for them and can be a really nice way to express non-abandonment. Making that type of commitment to a patient and family can be a really powerful statement. An explore statement just shows that we want to understand better. Emotion cues can be expressions of underlying meaning or underlying concerns. So an explore statement really tries to get at that. We also want to make sure that we avoid judgment when we use explore statements and that we're really coming from a place of curiosity. And then silence, intentional silence shows that we value their processing. We do want to use it intentionally because too much can leave people feeling uncomfortable. And silence can be used in a lot of different situations, but it's often particularly effective after we've delivered serious news. We tell them that serious news and then we are intentionally silent. So we're pretty commonly faced with statements of emotion from patients or their family members, and our gut instinct might actually be to respond with information. But using a nurse statement allows that emotion to be seen and addressed. It reinforces rapport, and then it allows us to get to a point of providing the really important expertise and information that we have to share. So, as an example from our original sample case, one of the parents of that baby might make a statement like this saying, "How can such a tiny baby endure so much?" And we might initially be tempted to offer reassurance about pain and sedation medicines, or the physiologic resilience and drive to survive of infants, or how we're using our various medical technologies to support that baby's body. But at the root of that statement, I think, is emotion. And a nurse statement allows us to recognize and address that emotion. So, in response to that statement, how can such a tiny baby endure so much? A name statement might be something like, "It must feel unbearable to watch him going through this." An understand statement might be something like, "I hear you saying that it feels like we're asking a lot of him." A respect statement could be, "I see how committed you are to supporting him through this." A support statement could say, "We're going to be here with him and your family on this journey." An explore statement might be saying, "Will you tell me more about what you see him going through?" And then, of course, there's that intentional presence, or our use of intentional silence. And again, using the nurse's tool, using one of these nurse statements to express empathy is important because empathy allows us to better connect with our patients and families. It allows us to better understand their perspectives and then to provide them with the information that they need to make value-based decisions, ultimately helping to position them to flourish. The next palliative care grounded communication tool I want to offer is intentionally integrating that child and family story in our communication, specifically through personhood questions. And these 7 personhood questions are a way to intentionally elicit their narrative, their family story, and then how that affects how it plays into their current medical journey. So this figure is a visual model of healing. And the authors here, who also work with Vital Talk, use a house to try to represent a climate of healing, and also acknowledging that a home has to be intentionally built piece by piece, brick by brick, to achieve that collaborative plan of care that you see at the top of the roof. So, built on the foundation of rapport, and then critical to framing out the home, is that family's personal and medical story. And the 7 personhood questions can be used to guide us in intentionally eliciting that family's narrative. When I teach those personhood questions to trainees, I use this mnemonic just as a memory cue. The mnemonic being kids chat. So, meaning key people, illness experience, daily life, strengths, concerns, hopes, assessing perspective, and then tuning. So, kind of going down that mnemonic, when we're asking about key people, we're asking things like, are there important people in your life? We're asking about maybe family structure, communication styles, how they prefer to make decisions. When we ask about illness experience, then we're asking about their prior experiences with illness themselves or in caring for others who are seriously ill. So that could include asking something like, how has this illness impacted you and your family, be it the current illness or a prior experience with an illness? Asking about their daily life is really just trying to get at what a typical day usually looks like for that family. And that could include the parents' background, their occupations, formative experiences they've had, maybe how they spend their free time. Their strengths is asking, where do they draw their purpose or their strength from? You might say something like, where do you draw the strength to get through every day? And asking about strengths can be a really important opening to ask and allow them to share about the spirituality. Concerns is just that, it's focusing on their current concerns or worries, either right now in the moment or in the coming future. And then alternatively, their hopes. What are they hoping for in the coming days, weeks, months? Assessing their perspective is really asking about their perspective on their child's illness and care and how they think that things are going. And then I add this tune, the last T, as realizing that as we're asking these questions and we're getting a better sense of who this child and their family are, we have to stay curious. We have to ask clarifying questions. We have to tune our understanding to their unique experience. The third component of high quality family centered communication is that it is trauma informed, and really specifically nailing down that we use trauma informed language. Trauma-informed care is a set of principles and practices to improve the care of people who've had previous traumatic experiences. So yes, having a child in the NICU is a potentially traumatic experience, and parents may have already had traumatic experiences in their lives, of which we want to be mindful and respectful. So the trauma-informed care is summarized by these 4 R's, the 4 tenets, which are to realize the far-reaching impact and widespread, intersectional, uneven distribution of trauma, recognizing that exposures of some populations place them at particular risk of experiencing trauma. That could be folks who have lived in foster care, in poverty, those who are immigrants or refugees, or who live in or who are in underrepresented groups, who are more likely to encounter discrimination and then trauma, among others. Number 2 is that we recognize the signs of trauma in patients, in families, and in other folks like us who are involved in medical care, and recognize that could include symptoms like difficulty focusing, reaction to triggers could look like emotional lability. It could sometimes even look like seeming disengaged or having a flat affect. Number 3 is that we respond by applying policies that ensure understanding and compassion and ethical principles, including addressing those disparities that place some disadvantaged populations at risk of re-traumatization. And then 4 is that we want to resist re-traumatization. 2 very tangible ways that we can resist re-traumatization are by avoiding language pitfalls and then asking permission. So common language pitfalls include terms that veil value judgments or they carry inherent subjectivity with them, words like futile or suffering. And I'd love to refer you to a mentor and colleague's paper, Dr. Aaron Whiteman, on the 4 horsemen of clinical language for some further discussion of similar terms. And another example might be using the phrase refusing care, because when we say something like that, we're really failing to recognize that the potential of past traumas and the risk of re-traumatization. So in addition to intentionally avoiding these language pitfalls, we also should be asking permission. And when I talk about asking permission, it's not anything fancy or complicated. It's really exactly what it sounds like, that before we share information, or maybe even before we change the conversation to a more sensitive topic, that we ask permission to do so. That offers that family some control in what generally can feel like a powerless situation. It also ensures that they are at a point to actually receive the serious news or information that we have to share, or to talk about something that's more personal to them. So when we integrate these palliative care rooted communication practices, demonstrating empathy, intentionally integrating a family story, taking a trauma informed lens, those are active ways to help move families toward post-traumatic growth and then ultimately flourishing. Post-traumatic growth is a state in which traumas can lead to positive changes in somebody's relationships, their self-perception, or even their life philosophy. So people who have post-traumatic growth take this intense trauma-inducing experience and are able to channel it, to use it to positively influence their life going forward. And there's good evidence that parents of children in the NICU and of those with kidney disease can experience post-traumatic growth. In one study, 3/4 of parents identified having a child in the NICU as an initiation experience that then prompted their own post-traumatic growth. And in an interview study of parents of kids on various types of dialysis, caregivers spoke of their experiences with post-traumatic growth in their child's care journey. They described it as an opportunity to gain wisdom, to gain insight, and to assume a more holistic approach to both life and caregiving for their child. That study went on to show that that type of post-traumatic growth was particularly attainable when caregivers had a high level of trust in their care team. Similarly, in a study of parents of infants who had congenital heart disease and were in an ICU, those who reported that they experienced more family-centered care then had lower risk of post-traumatic stress symptoms, lower symptom severity, and generally a lower risk of PTSD diagnosis at the time of discharge when compared to parents who reported lower family-centered care perception. So again, when palliative care rooted skills like demonstrating empathy, integrating a family story, having a trauma-informed approach, when those are utilized, it helps to create an environment that's conducive to post-traumatic growth. I also just want to briefly mention we've been discussing primary palliative care skills, particularly those that are focused on delivering family-centered communication, and that those can help minimize trauma and enable post-traumatic growth and flourishing. But a question I'm often asked is whether we might be causing trauma by pursuing specialty palliative care consults. And that worry is reflected in how often kids with kidney disease receive palliative care consults. In one multi-center study of children's hospitals in the United States who had specialty palliative care teams, of all the kids who received palliative care consults, fewer than 3% of those had kidney disease. So a couple years ago, my team and I performed a nationwide survey among pediatric nephrologists to try to better understand some of the barriers to palliative care integration. And you'll see from this figure that many nephrologists, over half, worry that parents will think that they're giving up on their child if they pursue a palliative care consult. And nephrologists just generally are concerned about how parents perceive the palliative care consult, about its palatability. About 40% worry that it might just not be acceptable to the parents or that it could undermine the parents' hope. There's been work done in peds oncology investigating those family perspectives on palliative care. And in that particular peds oncology study, 70% of caregivers and 98% of kids who had cancer diagnoses had never heard of the term palliative care. And of these really small portions who were familiar with it, none of them held a negative opinion. So knowing these concerns from our prior work of the peds nephrologists and the importance of avoiding harm, of trying to avoid re-traumatizing these families, my team and I recently surveyed parents of children anywhere from infants up to 18 years old who had CKD 3, 4, or 5, including those who were on dialysis or who had gotten a kidney transplant. And we asked about their perceptions of palliative care. And interestingly, several of the parents in our study, over 2/3 here, were familiar with palliative care. Of those who were familiar, just one reported a negative attitude toward it, and all the other parents had either a neutral or actually a positive perception of palliative care. Then when we gave the entire group a definition of palliative care, and we asked how including the palliative care team might impact their child's care, small numbers there at the bottom of the figure, you can see about 30% of parents thought that it might take away from their hope. But the majority of parents, over 3/4 in all of the 4 remaining categories working from the top down there, thought that it would be a good addition to their child's care, that it would help their family, that it would help with treating their child's symptoms, and that it would help with making medical decisions. So taking this together, I think we can say that rather than being a potentially traumatic experience, families actually perceive that a specialty palliative care consult offers a great amount of potential benefit. I also just want to briefly acknowledge that specialty palliative care is a limited resource. Some of us might work in hospitals where there isn't a specialty palliative care team, or there is one, but they have incredibly limited access, and that's a very real challenge. To try to address that limitation, my team and I have proposed the use of a pediatric nephrologist who has an expanded palliative care skill set, like myself, to offer advanced symptom management, both physical and psychosocial, as well as complex serious illness communication, as well as then serving as a funnel into the limited resource of the specialty palliative care team. Locally, we are piloting a model currently where I provide kidney palliative care consults just as on an as needed basis whenever partners in my practice identify needs. And using that model for some families, it's gone on such that I have developed ongoing relationships with them to support some of their chronic needs. For others, then I've been able to assist my partners in collaborating to manage needs. And then in other cases, then I have served as that funnel and worked with our local palliative care team to serve families with more complex needs. And I think this is just one potential way to better meet the needs of the families that we serve and to work to preserve that limited resource of specialty palliative care. So, to close, the circumstances that our patients and families are in that are imposed by their kidney disease and their critical illness are not conducive to their flourishing, and they're at high risk to encounter trauma. Palliative care, both primary and specialty, offer a way to help minimize their suffering. And in particular, when we do things like demonstrate empathy, integrate their story, and take a trauma informed approach, these are communication tools rooted in palliative care that we can integrate in our practice now on an individual level. And when we do so, when we intentionally leverage our primary palliative care skills and then the specialty palliative care team, we do it with the understanding that those circumstances in which these families live and grow and evolve are at a high risk of inflicting trauma, but that palliative care offers a way to help mitigate suffering and enable them to flourish, to live their very best lives every day of their lives, whatever that means for that particular child and their family. To close out, I'd just like to offer some additional resources for building up your primary palliative care skill set. I mentioned Vital Talk briefly, this evidence-based communication curriculum program. They have a variety of different courses available, but one that I really love that they have access to is a free app that's called Vital Tips. You can basically use it in the moment, just in time before you're going to go in to have a serious illness conversation. And then you can also reference some of the works from our team where we talk about building your primary palliative care skill set. And with that, I'd like to thank everybody for your attention and for the opportunity to speak today, and I'd love to take questions.
Thank you, Taylor. That was so good. I see Marissa over there clapping too. That was really wonderful, and I can't tell you how valuable that is for my own practice. I did, before I forget to mention it, put a survey in the chat. If you attended today, if you could please fill that out for us. That's really valuable information for Marissa and Mamta and I as planners for these things, but also for Dr. House as she's providing this sort of talk around the country. I'm sure we can't be the only people wanting to hear this. So hopefully, if you have a chance, you could fill out that survey for us. But in the meantime, we would love to have a little bit of question and answer with Taylor, who's been kind enough to share in the last 10 minutes or so of her time with us to do that. So are there any questions or comments about our talk?
I had two questions. And first of all, I love this topic because I feel like in the adult ICU, it's almost like a reflex to get palliative care involved, but it's really, I think, underutilized in the pediatric setting, especially in the NICU. But I had a question with I feel like the kidney is such an obscure topic to parents sometimes, and they don't really know what the kidney is, what it does, especially in a baby that size. And if you run into the issue of like parents understanding kidney pathology just in general, and then the integration of symptomatic management from palliative care and how you navigate that. And then with the model that you describe, is that like, and this is going to be hard to answer generally since every family is so individual, but are those topics that you're trying to like really hit all at that first visit to build all that rapport, or is that something that you're spreading over time since it can be a lot for a family to absorb?
Yeah. And Alex, will you clarify for me? Was the first question, are you kind of asking like how do you kind of go about involving the palliative care team, like introducing that to the family?
Yeah, because I mean, I think in general, issues that I come up with is like what is the kidney, and then what like how does palliative care fit in with with kidney, with pathology in
Yeah.
your patients?
I think that's a great
Um,
question, Alex, too, because I was just going to say in my own practice, and we've learned from some of the stuff that Michelle has sent us and done that parents don't even know that baby's having trouble with the kidney sometimes in the NICU. You don't see it, right? They don't get
Right. Yeah. And like
lethargic, they don't change colors, they don't have blood gases, they don't have all of the kind of signs and symptoms that we see from some of the other pathology in the NICU. So I think that's a really thoughtful question, Alex.
yeah. And I think that in some ways also kind of goes back to this idea of like the fast brain, slow brain, in that if we're ever going to get them to a place where they can receive this really nuanced information that we have to share with them about their kidneys, their child's kidneys, then we have to attend to that emotion so that they can ever get there. Um, like as you're kind of asking about introducing the palliative care team, actually in one of those papers that I referenced of our work, we offer some phrases for actually introducing the palliative care team. So it might be, saying something like they're a team that adds an extra layer of support for kids, for their families, and for their teams. It might also be saying something like, in a situation like this in the past, I found it really helpful to have palliative care in that they can help us with X, and I would like to have them involved. So there are some just kind of generic tips out there that you can kind of go to on ways to introduce the palliative care team. And that can be a service to help you to help that family to move from, we're in our fast brain, we really can't process this information. On top of it's really complicated information, to now we're getting to a place where it's not like the emotion goes away, but we're able to better leverage that slow brain part. Um, the other question I think you asked was like, when I'm actually delivering palliative care, then what does that look like? Like, are you sitting down and doing a 3 hour conversation to try to get at some of these questions? And the short answer is no. I think it depends a little bit on the circumstance that you're in. So sometimes we have to make really quick decisions, right? Like we don't have that luxury of hours. Sometimes we need to talk about initiating some kind of kidney replacement therapy in the next, minutes. And in that case, I try to like very briefly understand what matters the most to that family in their child's care, like what their general understanding is right now, really focusing on assessing that illness perspective right now. Um, and what they're hoping for their child down the road, to make sure that the decisions that we're making don't contradict what they're hoping for and planning for with their family, recognizing that there's time constraints there. So we're not going to get to all those 7 personhood questions. As it's somebody that's like my personal patient, or I'm on call, I'm going to be seeing them for several days over the course of a week, then I basically try to just like integrate, like pepper those questions throughout our conversations and our time together. Because, also families probably are not going to want to sit down and give you the answer to all those questions. And they need to build some trust with you too, that they can share these really intimate parts of themselves and their experiences. It's a little bit different than whenever I'm actually asked to do a kidney palliative care consult, because I have 90-minute visits. So I actually can sit down and say, like, the goal of our visit today is really for me to get to know you and your family better. And then asking permission to ask, what's going to feel like a million questions to try to understand what life is like for you and what I can do to help make that better for you.
Awesome. Thank you.
Sure. Thanks for the question.
Taylor, that was amazing. I just quick question. Who is a part of your team? Um, do you have families that have benefited from, right, longitudinal follow-up with you, right? Which is so unique and special that maybe then help other families to get on board. I'm just curious how your structure is.
No, it's a great question, Marissa. I'm like smiling because the team is like me whenever it comes to the clinical care. I have been really lucky that my division is willing, that the nurses who I work with regularly are on board with like filling in the gaps of what we would need for nursing support in that same way. And the social worker on our team, like I basically just, went to her feet and said, please help me. I highly recommend ingratiating yourself to your team social worker. And so they have just been awesome to kind of pick up some of the slack where we don't have all of the other interdisciplinary team members that really long term we need and would hope to have. Part of building that program, though, is trying to show that there is a need and a benefit to our leadership and to the financial book side of things. And so as I am doing these as needed consults, then we're keeping a registry of families that we serve in that way, and some basic information about their care and what the consult was for, and then what that trajectory of our involvement or not went on to look like. So we don't have families who are directly involved in that way right now. I think that's incredibly important thinking about the future. And there are a few of my own personal patient families who, once they kind of figure out what I do, then they're really awesome to be like, oh, if you ever need feedback, please tell me. I'd be happy to let you know. And I do, like in clinic yesterday, I asked a mom who's also a nurse, you know, the amount of uncertainty that had gone along with her child's diagnosis. Like, how did she balance being a nurse who deals with uncertainty a lot, and then also being a parent who it's really challenging to deal with uncertainty in your child's care? And so once I'm in a really close rapport with a family, then I use that as an opportunity, like almost as part of those personhood questions of where are their gaps, where could we be doing better, and just kind of like constantly thinking about noodling on ways to build that into my research portfolio.
Awesome. Thank you.
Taylor, are most of your like NAF palliative care consults outpatient or inpatient? Like, are they longitudinal patients who are transitioning from to like dialysis? Are they like acute CRT or prenatal consult or?
They're exclusively outpatient right now. The transplant program actually is the place where I've gotten the highest number of referrals from. Whenever they're inpatient, I think it's a little bit of a different resource equation, because in our practice locally, we do have a specialty palliative care team. They don't regularly provide outpatient care. So there's more of a gap, more of a need in outpatient palliative care delivery. So that's somewhere that I feel like I can really serve and try to help fill that gap a little bit more. Whenever they're on the inpatient, they're receiving inpatient care, then oftentimes they may actually have more escalated needs, meaning that they do need to be referred into that limited resource of specialty palliative care. If they're more subtle needs, then usually that looks like me scheduling a follow-up with them once they are outpatient. And we've really tried to get family feedback on like using telehealth visits instead of making them come back for additional visits. And even trying to figure out ways, like from a billing perspective, can you see two kidney doctors in one day if one of them does have additional palliative care expertise and they're delivering palliative care to you, not nephrology palliative care to you? And the answer to that is yes, but there's like some nuance to that too.
All right. Taylor, thank you for your time and your expertise and for sharing that with us. We're really so grateful. Everybody who joined us, thank you so much for joining us today. I was going to throw up here real quickly. Let's see if I can share my own screen here. We'll make this full screen. We do have one more learning opportunity today for the NKCEC. This evening at 8 p.m. Am I getting that right, Marissa? 8 p.m. Eastern time, which is all of these other times on the other side of the world. The Australia and New Zealand chapter of the NKC is hosting their first educational symposium, and our very own Dr. Michelle Starr is going to be talking about neonatal hypertension in that hour. So when you get home and you are enjoying your holiday festivities at home tonight, maybe log in and learn a little bit something about neonatal hypertension if you have the chance. The sign-up code is here on the screen, so if you have not registered and you'd like to, it is open to anyone. We'd love for NKC members and non-members to join. So that is our other educational offering this evening, and a great way to support the ANZ chapter. And I think, Marissa, Mamta, I think that's all we have for today, huh?
Thank you so much, Taylor. Again, really
Thanks for
appreciate
having
it.
me. I appreciate it.
Good to
Thank
see everybody. Thanks for being here.
Thank you so much. Thanks, Heidi.
Yeah.